oration on recurrent pregnancy loss. What is the evidence? I would request Shweta to read out the oration.
Thank you, Dr. Surveen. It's an absolute honor and pleasure to read, the oration, which has been conferred to Dr. K. Jayaprakashan, subspecialist and associate professor in reproductive medicine, Nottingham University, fertility unit lead and IVF consultant, Royal Derby Hospital and Care Fertility UK, for the topic recurrent pregnancy loss, what's the evidence, during NOESIS 2020 held on 8th August 2020 on the virtual reality platform. By bestowing this oration on him, we acknowledge not only his continued contribution to the field of obstetrics and gynecology, but also for being a beacon of light for members of varied generations to explore, comprehend, and dedicate the discoveries for overall patient care. Wishing him many more years of academic excellence. Sir, I think we are really looking forward to listen about what is the evidence when it comes to recurrent pregnancy loss. And I think we will have lots and lots of take-home messages. Could we have the next slide? Or...
Next slide, please.
Yeah, could we have the next slide? So this, we are presenting with, a lot of gratitude, a little token of our appreciation to you. And now the dais is yours, sir. Please take over.
Thank you very much, Chairperson. Can you all hear?
Yeah, we can hear.
Okay. And you can see my slides as well, yeah?
Yes, very clear.
Okay, great. Yeah, thank you very much. First of all, I would like to thank Dr. Kunjumaideen and Perindalmana ONG Society for inviting me for speaking at this virtual conference. And I would like to take this opportunity to congratulate the team for organizing such a wonderful platform. I know as being a Keralite, I feel for the accidents that has happened over the last couple of days due to bad weather and other factors. And it is quite paining to hear those accidents. And my thoughts and prayers are with the family and people affected. So now going back to the topic, and I understand, when I heard from Kunjumaideen and Chairperson that you're all waiting for this talk. And I'm not absolutely sure, but I'll try my best to meet the expectation. So first of all, with regard to the recurrent pregnancy loss, before looking into the recent evidence base, let us go through some of the basic traditional facts. We know that recurrent pregnancy loss affects 1 to 5% of the couples, and the prevalence actually vary depending on the definition that we use. And no doubt, we all agree that it causes significant psychological and emotional distress to patients, and equally, it's frustration to clinicians, us, who are looking after those patients. And about 50 to 70% of cases, we can't identify a cause, and we term it as an unexplained recurrent pregnancy loss. And on a positive note, and in fact, this is a reassuring thing, that over 70% of couples have a successful outcome in the subsequent pregnancy, even if we are seeing them in our recurrent miscarriage clinic. And I think I will probably start, and this is more or less my conclusion, that the evidence is limited still, and the controversies exist. And we know over the last decade, there has been a lot of three major international guidelines that has come out. And the first one was the RCOG one, which is produced in the UK in 2011. And then subsequently, the ASRM has come up in 2012 with a bit of modification 2013. And then recently, the ESHRE has come up with the recurrent pregnancy loss classification. And as I mentioned about, with regard to the evidence base, they have produced 77 recommendations, and 60 of them are evidence-based, and 17 of 77 were good practice points. And the first and foremost is there is no high quality evidence that they could see to derive a recommendation. About 10 recommendations were from moderate quality evidence, and in fact, nearly 60% of recommendations are based on low quality evidence, and over 25% are very low quality evidence. And in fact, their conclusion was evidence-based practice in recurrent pregnancy loss is not yet feasible. So I have broken the suspense just now, but I will try my best in my talk, going through or integrating with some traditional concepts in recurrent pregnancy loss, and what are the controversies and variations in recommendations of all the 3 international guidelines. And I will incorporate some of the recent RCTs, which is actually published after, particularly after the ESHRE guideline, and then some of the meta-analysis. So as I said, we have got these 3 guidelines, and the first and foremost is how we define the recurrent pregnancy loss. And the first one, the Royal College, and that is what we have been using traditionally in the UK, which has come out in 2011, and we define as pregnancy loss up to 24 weeks, and if a couple has or women has lost 3 consecutive recurrent pregnancy losses, then you term it as a recurrent pregnancy loss. And the ASRM has modified a little bit in 2013, and they have said 2 consecutive loss. And in fact, the ESHRE has said 2 pregnancy losses up to 24 weeks, and they define pregnancy as evidence of a positive HCG. And they haven't termed, or in fact, we could include whether it is a consecutive or non-consecutive. And this is mainly based on the proportion of the positive test results that we see. So whether it is 2 miscarriages or 3 miscarriages, the proportion of positive results are more or less the same. And same thing with regard to the management aspect as well, because the management aspect is more or less the same as well. And I'll show you some of the data of comparing between 2 and 3 miscarriages. And you see here the prevalence of the chromosomal abnormalities. It hasn't shown any difference, so it's about 5% on both groups. And same thing with the uterine anomalies, antiphospholipid antibody syndrome. And if you look at some of the hereditary thrombophilia as well, whether it is 2 miscarriages or 3 miscarriages, the prevalence is more or less similar. And looking at the abnormal thyroid function is again, there is no difference whether it's 2 miscarriages or 3 miscarriages. So I think we could probably say overall, we can recommend a referral to a specialist in recurrent miscarriage after 2 pregnancy losses. And after that, the decision to start investigation, we probably have to think a bit, and I will go into detail about it, and it has to be individualized or customized set, and a decision has to be made following a discussion with the couple, with the women. And now just moving on with looking at risk factors. And in fact, before going through all the risk factors, let me tell you the maternal age and the number of previous miscarriages are the key risk factors, and they independently predict the future outcome. And there is no doubt that all of us are very much aware that as the age advances, the proportion of the aneuploid embryos that are created increases, and therefore increasing the miscarriage. And as you see here in the prime time, probably for fertility is in 20s, and the miscarriage rate at that age is around 11-12%. And in fact, when it moves on to women's age of 40, it goes to up to 51. In fact, at the age of 45, it's about 93% chance of miscarriage. And what about the number of previous miscarriages? And as you see here, anybody who hasn't had any miscarriage, and probably about 11% miscarriage on the future pregnancy. And as the number of miscarriage increases, see here, anybody who has got a 6th miscarriage or more, the chance of having a recurrent pregnancy loss is around 60%. And if you look here, as the number of miscarriage, I mean, obviously that, we know that one of the common causes, if the embryo or the fetus is aneuploid, the miscarriage, the nature takes its own course, and therefore miscarriage happens. And the number of, or the proportion of the aneuploid miscarriage remains the same as the number of miscarriage increases. So what actually increases? Actually, the euploid miscarriages increases. So possibly that, and that is one of the key reasons why, as the number of miscarriage increases, probably we have to expand the panel of investigation, because those are the group where we are likely to find some of the positive causes. And the other factors, the risk factors, are the BMI. So as the BMI increases, the risk of miscarriage increases. And as you see here, this is a BMI of less than 25. That's a normal BMI versus over 25. The odds ratio is about 1.3. And if you're looking here, less than 25 normal BMI versus probably the obese group that we can define if the BMI is more than 30, and the odds ratio has gone up to 1.52. So as the BMI increases, there is an increase in risk of miscarriage. And underweight is also another risk factor. Smoking, excessive caffeine intake, alcohol intake, in fact, these are all in a dose-dependent manner, increasing sporadic miscarriage. I mean, there isn't any evidence or there isn't any data with regard to the recurrent pregnancy loss. So all these data are mainly from the sporadic miscarriage population. So as I mentioned before, maternal age and the number of previous miscarriage independently predict the future outcome. And obviously, there are some other factors as well, the family history of recurrent miscarriages. And there is a recent systematic review has shown that if there's a family history of miscarriages, it probably nearly doubles risk of miscarriage of women. And that may possibly be related to genetic polymorphism relating to immunity or clotting or angiogenesis. And maybe even they are sharing similar environmental and lifestyle factors. What about male age? As the male age increases as well, probably that increases the epigenetic or genetic sperm abnormalities. And it has shown that once men becomes age of 40, there is a statistically significant increase in risk of recurrent pregnancy loss. One could argue that elder men are likely to have elder female partner, and therefore possibly there is a residual maternal age effect. But having said that, most studies have reported an independent effect of paternal age. Linking with the recurrent pregnancy loss. Moving on to causes, and obviously our investigation relating to the causes, and I've gone through some of the environmental factors, and the genetic factor is well known. So if anybody who has got balanced translocation, they will be phenotypically normal, but however, to the fetus, they may pass on half of their chromosomes, and therefore it becomes unbalanced, and therefore increases the risk of recurrent miscarriage. And these are the prevalence that we have looked at our own data. And which was published a couple of years ago. And this is more or less similar to what is published in the literature. And this is another paper which has looked at over 1,000 women and men, looking at what type of chromosomal abnormalities. And the one chromosome abnormality that we have seen is about balanced reciprocal translocation. And of course, that there are other group of inversion as well. So the genetics and then the hereditary thrombophilia. This is a common factor for the venous thromboembolism, and none of the international guidelines have recommended that we should do a hereditary thrombophilia screening, because it hasn't shown that there is a direct link with, particularly with the first trimester miscarriages. Having said that, the RCOG guidance have said if there is a second trimester miscarriages, then yes, it is advised to do a hereditary thrombophilia screening. Antiphospholipid antibody syndrome screening, yes, that is shown a close link. Endocrine problems, and one of the common thing that we have to rule out is the thyroid abnormalities. And also diabetes. There is evidence that the controlled diabetes doesn't increase the risk of pregnancy loss or pregnancy problems, but uncontrolled diabetes can. And obviously other conditions like PCOS and prolactin problems, but those investigations are mainly if there are associated symptoms. Uterine abnormalities, that is including congenital uterine anomaly or fibroids, for example, submucous fibroid, potentially increase the risk of miscarriage. The male factor, we haven't assessed, and we don't assess in our routine practice in our population, but the ESHRE has recommended, and I'll come into detail. So in our population, and I think this is more or less consistent with what the data has been published, when we looked at our panel of investigation, around a third of women has been diagnosed as unexplained. And majority of the unexplained population would probably have the chromosomal problem with the pregnancy, which are most of those chromosomal abnormalities with the fetus is non-recurring. But that probably would explain around 46 or 50% of pregnancies could be related to the chromosomal problem with the fetus. And now let me take you through this. I'm sorry for this busy slide, but I just wanted to show you all recommendations and a comparison of different in 3 guidelines. What I've said, the general aspects that we have already looked into, the medical history and the family history of all those, and the genetic point of view, the RCOG, and that we have been doing traditionally in the UK, that we do send the products of conception on third and subsequent miscarriages. And that is basically that if we find any chromosomal abnormality, mainly for unbalanced translocation, not for aneuploidies and things, but for unbalanced chromosomal translocations or other structural abnormalities, then we do the parental karyotyping. And the ASRM has said, do parental karyotyping for everybody. And the ESHRE has come saying that parental karyotyping is not on a routine basis. And that is because even if somebody has got a balanced translocation or other structural abnormalities, around 70% of those parents are likely to have a normal outcome in a couple of years' time. But they have said analysis of pregnancy tissue mainly for explanatory purpose of that miscarriage. And that's what the guideline says. Hereditary thrombophilia screening, and as I said in our COG, they say if there is a second trimester pregnancy loss, then do it. And all the other guidelines said do it only in the context of research. Antiphospholipid antibody syndrome, yes, categorically all the guidelines have said do anticardiolipin antibodies and lupus anticoagulant and do it 12 weeks apart. And the ESHRE guideline has said that along with it, you add the beta-2 glycoprotein as well. Endocrine factors, TSH and HbA1c by the ASRM, and the ESHRE has said about TSH and TPO antibodies. And if it's abnormal, then do a T4. Uterine anomalies done by a scan, and that is more or less consistent. The male factor, there hasn't been a sort of a consistent advice. And the ESHRE has said, do not a semen analysis, but do a sperm DNA fragmentation index. And that can be considered for explanatory purpose. And just some of the evidence base for those. And as you see here, this is showing that the TPO antibodies and the systematic review and the meta-analysis has shown that if a woman has got a TPO antibody positive, the odds ratio of 1.94, so there's about 94% increase in the risk of having a recurrent pregnancy loss. So there is an association, but this is a very important study that is published in the UK called Tablet Trial. We've been part of this. And if somebody who has got a TPO antibody positive, and if you treat with thyroxine 50 microgram pre-pregnancy to the end of pregnancy, you see the live birth rate. There hasn't been any difference. See, it's more or less a similar with p-value of 0.97. So, sorry, the relative risk of 0.97. So it hasn't shown any benefit if somebody who's got TPO antibody positive giving thyroxine. What about subclinical? I mean, overt hypothyroidism, no doubt, there is a link with recurrent pregnancy loss. What about subclinical hypothyroidism? And again, a systematic review which is published this year has shown they couldn't do a meta-analysis to show a sort of overall statistical analysis. They did find a few studies, and apart from one study where they included about 210 women, but some of the other larger studies have shown the prevalence of subclinical hypothyroidism have been similar in both the groups, whether it's recurrent pregnancy loss or the other group, the control group. And what about treating them with the thyroxine in a subclinical hypothyroidism and recurrent pregnancy loss? Again, it hasn't shown any benefit. So this is contrary to some of the recommendations made by the ESHRE, but I'll come into detail in a minute. So this is regarding the DFI, and a systematic review again published this year has shown that the DFI, there is a link with the recurrent pregnancy loss. And now that the ultrasound abnormalities of uterus showing adhesions or submucous fibroids or uterine anomalies, yes, it has. There is a direct link with the miscarriage, and therefore, recommendation is to treat those abnormalities. And even if you see a hydrosalpinx, yes, that is more or less linked with fertility. Probably they may not become pregnant, but if unilateral hydrosalpinx and if they conceive, and there is an increased risk of having a miscarriage. So I have gone through what the guidance says, and as a sort of a summary of the investigations, and I've categorized them into recommended, and then we individually assess, and there are some with no evidence to do. No doubt that we do ultrasound scan to rule out any anatomical abnormalities. With regard to the karyotyping and the genetic abnormalities, to be honest, in our practice, what we do is in a primary recurrent pregnancy loss, that means those who haven't had a live birth before, we do a parental karyotyping straight away. And in fact, we do see women who have had 3 miscarriages. Of course, that we do accept even if they have had 2 miscarriages, but generally if 3 miscarriages or more, and if it's primary, we do tend to do a parental karyotyping straight away. And we do tend to send all the pregnancy tissue for karyotyping from 3rd miscarriage onwards. And with regard to the thrombophilia screening, as I said, there is no question about antiphospholipid antibody syndrome, and this is something that we routinely do, anticardiolipin, lupus anticardiolin beta-2 glycoprotein that is recommended. And hereditary thrombophilia, we do send if there is a family history of thrombosis and a family history of second trimester miscarriage, and also if there is a personal history of miscarriage, second trimester miscarriage. With regard to the infection screening, it's a routine screening that we do, a rubella screening, but for other infections like bacterial vaginosis or chlamydia, that is depending on the clinical situations, and there is no role for torch investigation that we used to traditionally do in many years ago. Immunological aspects, we don't routinely do, and the general recommendation is there is no evidence of testing these and using immunomodulation medications. Having said that, the ESHRE has said about anti-nuclear antibody, but I'm not sure why. And they have said that it is probably more useful for explanatory purpose. But if you have somebody who's got a rheumatological conditions and things, then yes, it is possibly worth doing anti-nuclear antibody screening. Endocrinology aspects, then routinely do a TSH, and then ESHRE has recommended TPO, but one aspect is probably if somebody who's got TPO antibody positive, then there is an increased risk of having hypothyroidism in the future. And therefore, when women become pregnant, then it is important that we do check their thyroid function test at around 6 or 7 weeks of pregnancy, so that if there is any sort of overt hypothyroidism observed at that stage, they could be treated. And the other investigations like prolactin, then do if there is a suspicion about prolactinoma or other symptoms. Testosterone and SHBG is any suspicion about PCOS or hyperandrogenemia. Diabetes is routinely tested. We do look at the HbA1c, and the main factor there is it may be beneficial, but then obviously that we don't have any sort of a specific treatment apart from lifestyle, advising them to do a lifestyle changes and using antioxidants with a question mark. Management, as I said, maintain normal BMI, dietary advice if there is a raised BMI, and obviously from the neural tube defect point of view, if there's BMI of more than 30, advise high dose folic acid. Smoking cessation, limit alcohol intake, vitamin D is routinely recommended. Moderate exercise, not too much, but moderate exercise, and limiting caffeine intake, although the evidence is not strong, but probably limiting caffeine intake to 3 cups a day. And for men, again, more or less, the lifestyle advice the same, antioxidants for men. And obviously, if there's any cost, then treat them. And as a comparison of all the guidelines, the specific treatment, for example, like balanced chromosomal abnormalities, then genetic counseling and IVF and pre-implantation genetic testing it can be offered, and it's optional. There is limited and there is a consistent guidance for that. Antiphospholipid antibody syndrome, yes, again, there is a consistent guidance about low-dose aspirin, heparin. And in fact, the ESHRE has advised that you start aspirin even before becoming pregnant, pre-conception stage, and then you carry on with the aspirin during pregnancy, and then add low molecular weight heparin throughout. Thrombophilia, there is insufficient evidence, and the ESHRE has come up saying it's not recommended unless in the context of research. And there is a trial going on in the Europe led by Professor Siobhan Kinby in the UK called ALIVE-2 trial, and hopefully that will answer some of those about the prevalence of thrombophilia and recurrent pregnancy loss and whether it's worth treating. Endocrinology aspects, no doubt that if there is a thyroid dysfunction, then treat it. If there is a problem with the diabetes, if it's uncontrolled, it is better to control the diabetes and then advising them to start trying to conceive. And if there's a hyperplastinemia detected, then treat that. Uterine anatomy, consider surgical corrections, and the ESHRE has recommended septal correction in the context of trial. In the UK, the NICE in 2015 has come up saying that there is evidence from controlled studies, not from randomized controlled studies, and the NICE advises that septal division. And I think, almost all of us, and I'm sure in India as well, we do practice septal division, particularly with the history of recurrent miscarriage. Unexplained, there isn't any sort of a specific treatment and supportive care, and we do have a dedicated early pregnancy assessment unit and a recurrent miscarriage clinic, so that the people who are very much familiar with treating recurrent miscarriage will be able to support them. And counseling should be available. The SRA has come up saying there isn't any sort of therapeutic intervention, but which I'll touch upon briefly in a few slides. And no role of immunological treatment unless in the context of research for the immunological aspects. And this is just to show you about the management of APS and the data, and this is from Cochrane. Aspirin alone hasn't shown any benefit in improving the outcome, whereas if you're adding aspirin and heparin, that has categorically shown that improves the outcome of recurrent pregnancy loss. So let me just go through with you some of the trial that is mainly for the unexplained recurrent miscarriages, and which has been done in the UK. And one is called the PROMISE trial, and that is done in a very large population, a fantastic study, a high quality randomized controlled trial for recurrent miscarriage. And the definition was 3 or more miscarriages and not necessarily consecutive, and started using the micronized progesterone starting before 6 weeks of pregnancy. So as soon as the pregnancy is diagnosed and up till about 12 weeks, and live birth beyond 24 weeks as a primary outcome. See here, there wasn't any difference in terms of the outcome using progesterone in recurrent pregnancy loss. And did a subgroup analysis, and you see here whether it is 3 miscarriages or 4 or more miscarriages. Yes, probably the effect might be the benefit might be better. There could be a benefit, but the numbers are probably small to show that. And there was another trial by the same group, and again a high quality study. And I think you see that it's a fantastic study of recruiting about over 4,000 women. And this is mainly for threatened miscarriage. So anybody who's coming with bleeding during the first 12 weeks of pregnancy, starting micronized progesterone as soon as the diagnosis is made, more or less a similar dose, 400 milligram vaginally or rectally, because if the patient is bleeding and if patient accepts rectal administration, then rectal administration I'm using up to about 16 weeks. And the live birth rate live birth rate beyond 34 weeks was the primary outcome. And look at the relative risk, and there could be some benefit, and it was just touching the unity here, and with the p-value is not that far off of being significant. And did a subgroup analysis on this, and look at this. If somebody who hasn't had any miscarriage and they came in with the threatened miscarriage, there's no benefit at all with the relative risk ratio of 0.1. And if it is 1 to 2 miscarriage in the history, then you started seeing some benefit with the relative risk has moved to 1.05. And if somebody has got 3 or more miscarriages, and that come into the definition of recurrent miscarriage, and if they are coming with a bleeding, there is categorically a significant benefit in improving the outcome. So that shows some sort of a light that the progesterone may have some benefit. And the group has done a meta-analysis looking at all the other studies that has been published. In fact, the Cochrane also has done that as analysis, and it has shown that the progesterone use in both, this is a group of threatened miscarriage and this is a group of recurrent miscarriage, and both the group has shown that the progesterone may be beneficial in improving the outcome with the history of recurrent pregnancy loss. And you may remember that these 2 pictures that I have shown you earlier, as the number of previous miscarriage increases, the risk of future miscarriage increases. And the risk of future miscarriage increases basically not because of the increase in number of aneuploid miscarriage. It was mainly because of the euploid miscarriage. And maybe that this is explaining that as the number of miscarriage increases, there could be an underlying pathology or underlying reason why they are miscarrying. And in fact, because they are miscarrying euploid embryos. And that probably gives us a clue that the progesterone deficiency, luteal phase defect, although many of us started believing probably a few years ago that there isn't anything of that sort, but that gives us sort of some idea that there could be, but there isn't any test to look at the luteal phase dysfunction. And maybe this group, that means as the number of miscarriage increases, then there may be some benefit, and probably it may not be related to just the progesterone deficiency. Progesterone may have some form of immunomodulation effect, and that may be explaining this group may benefit by using the progesterone. And this is further showing in this as well, saying see here using the progesterone with no miscarriage in the previously hasn't shown any benefit, whereas as the number of miscarriage increases, see that increases the ongoing pregnancy at 12 weeks if you use progesterone. And if you're looking at the number of miscarriage less than 24 weeks, again, like, if it's no miscarriage before, maybe 1 to 2 miscarriage before, hasn't shown any benefit. But if 3 or more miscarriages, and if you're using progesterone, that significantly reduces the miscarriage rate. So as a sort of a summary of recommendations with regard to the management options, anatomical uterine problem, there is a reasonable evidence that if the submucous fibroid surgical treatment, there is again some evidence that treating the uterine septa or polyp or adhesions, but essentially considering that the surgical risks are higher for treating other Mullerian anomalies, this is not recommended. Surgical treatment for other Mullerian anomalies other than septum is not recommended. Genetic abnormalities, yes, if there's a structural rearrangement like balance translocation is diagnosed, then the pre-implantation genetic treatment is advised. And if somebody who has got, who can't accept that, and there are options of egg donation treatment or natural conception and then doing an antenatal evaluation. It is not recommended strongly about PGT and euploidy aspects, but it could be considered. Thrombophilia for antiphospholipid antibody syndrome, unanimously or consistently, there is recommendation of aspirin and heparin. There is no role for using aspirin alone, and it can be sometimes detrimental, especially that if there isn't any reason. Infection, antibiotics if there's any evidence of infection. Immunological aspects, so far, based on the recent information or data, there isn't any evidence of using prednisolone, IVIG, or intralipids or others, unless in the context of research. Endocrinology, diabetic control, and thyroid problem control. Treatment for subclinical hyperthyroidism and TPO antibodies is still under debate. But having said that, if you're not treating, it is important that they are being assessed at around 6 to 7 weeks of pregnancy, looking at the thyroid function to make sure that the thyroid is well within the normal range. And in case if it is subnormal, it is best to treat as fetus relying on maternal thyroid levels until about 12 weeks of pregnancy. Male factor, lifestyle modification, as we discussed, there could be some role of antioxidants. Unexplained, although there is no strong recommendation, there is some suggestion that we could use progesterone. And in my practice, we do prescribe progesterone, particularly for 3 or more miscarriages. And in fact, we do continue progesterone up till about 12 weeks of pregnancy. And in case if somebody who has had bleeding during the first 12 weeks, we do continue the progesterone up till about 12 weeks of pregnancy based on the evidence from the PRISM data. And the general aspects, as we discussed before, maintain normal BMI, stop smoking, tender loving care, and a dedicated clinic review, and limiting coffee to about 3 cups a day may be beneficial. So to conclude, everyone, we've gone through the definition, which I've said about the recurrent pregnancy loss, about of 2 or more pregnancy losses. And when we see them, it is always a shared decision to start investigating and consider an individualized approach and a customized set of investigation. And progesterone may be beneficial in recurrent pregnancy losses, particularly for higher order losses and if there is a threatened miscarriage. And the one key thing that when we see patients as well, we need to reassure them, and that is on a positive note, the most women will have a normal outcome. Thank you very much for listening. And this is just to share some of my nostalgic memories from my native place and around when I attended the meeting in Kerala and Coimbatore, where I've attended with my brother, my close friends. And I know we are missing at this juncture due to this COVID, and I'm really missing. I'm supposed to be in Kerala at this time because we have already booked tickets and I had to cancel. But having said that, although there wasn't any sort of a direct meeting, it is a good thing. Like Dr. Kunjumoyuddin and his team has arranged this virtual conference, and I would like to congratulate the team again for making such a unique virtual platform. Thank you very much.